Good afternoon, everybody. We still have lots of people joining, so we will start here in a moment. If you are a committee member, if you would put your name in the chat. If you are a committee member who's on the phone, if you would please unmute yourself and let us know that you are here. We should begin here in a few moments, but we are still waiting for a few committee members to join us. So just give us just another minute or two and we'll get started. Okay, so for those of you who have just joined us, we are just waiting a few more minutes to make sure everyone has a chance to jump on and attend. It is kind of an off-cycle time. Usually we meet at 2 o'clock and today we're meeting at 4. So we're just giving everyone another extra minute or so to jump on. If you are a committee member, if you would please put your name in the chat so we can capture it for meeting minutes. If you are a committee member who's on the phone and calling in, if you would please unmute yourself and let us know that you are here. We should be starting here in just a moment, another minute or two. Thank you. Okay, I don't see that Jesse Mandel has joined. Jesse, are you on the line? Okay, so Jesse might be running a few minutes late. Michael Hills, would you be able to chair this afternoon? Never mind, look who is just joining us. Let's just give her a moment to fully log in here. Again, if you are a committee member, please put your name in the chat. And if you are a committee member who's on the phone, please unmute yourself. Let us know that you are here.
Hi, this is Gina Tuttle with local health departments.
Hi, Gina. Thank you.
And Sharon, I've joined now too.
Yeah.
Hi.
Hi. Right as I was asking Michael if he could share, you jumped on. So thanks, Jesse.
Yeah.
So we do have a quorum, so you're good to start whenever you are ready. Thank you.
Okay, great. And thank you, Michael, for stepping in or being ready. Great. Well, welcome everybody to the gosh, what is this? The June MAC. You can tell that I'm jumping in. I was in another meeting, and so my apologies for being joining a few minutes late. But it's great to be here. Welcome to the June meeting, and look forward to the presentations that we have for today. So I will start with just an overview of, well, actually, before we head into the overview, first, can I get a motion to approve the minutes for the May meeting? If anyone has had the opportunity to look those over, I'll take a motion to approve the meeting minutes from May.
Jesse, I make a motion that we approve the May meeting minutes.
Thank you, Michael. Can I get a member to second that motion, please? Great. Thank you, Joey. All right, so with that, the meeting minutes are approved, and we can move on with the agenda, which is we're going to start with an overview of the budget process that Eric Grant is going to give us. So take it away, Eric. Thank you for being willing to share.
Hi, thanks, Jesse. So I will give this a quick overview for those of you who aren't familiar with it. I'm sure a lot of the members and people who have participated in the MAC over the years are very familiar with this process, but it's probably just a good refresher. So I do have a couple of slides because I'm a very visual person. I like to do slides, and I will make these available to anybody who's interested in having them after the MAC. So I've already sent them over to Sharon. So basically, I just first wanted to touch on the MAC and how it's involved in the budget process. So under Federal Regs 42 CFR 431.12 requires the creation of a medical care advisory committee. We have State Rule R414 1-9 that requires the MAC advise the Medicaid agency director. And then in the MAC bylaws, it talks about how it's the MAC is to provide information and interpretation of programs and budget requests to the public. So that all fits in nicely with the process that we go through for budgeting. So here's a little flow chart I threw together of how this process works. So up in the top left corner, you can see we have the MAC prioritization, which is the process we're about to engage in. Once the MAC has made its determination on what things it would like to prioritize, that goes to the division. We then look at those recommendations from the MAC and combine them with other recommendations that we might have as a division and send those up to the department. This will be the new combined Department of Health and Human Services. And they will look at those recommendations we as a division make and look at them in conjunction with the other divisions within the Department of Health and Human Services, and then make their recommendations. Their recommendations then go to the governor's office. And if the governor's office also agrees with those recommendations, they will end up in the governor's budget. And through that process, will be reviewed by the Social Services Subcommittee. Now you can see at the bottom, there's a whole other route to getting it to the Social Service Subcommittee, which is to have a legislative sponsor. But once it gets to the Social Services Subcommittee, it gets voted on by the committee members and prioritized, and then eventually gets moved up to executive appropriations. So that's really all I have on the slides. It's a very high level, quick and dirty how the budgeting process works. And I'm happy to entertain any questions if anybody has any.
Thank you,
Looks like
Eric.
it's not the case. So Jesse, I'll turn it back over to you.
Yeah, I guess I do. So, so this is the same process that do any other agencies? I guess I'm curious if you're aware of, or any other agencies follow a similar process.
I would imagine their processes are similar. I don't think, I would imagine some agencies have regulations to have a committee like the MAC, some may not. But as far as like the division and department prioritization, I would imagine that's constant throughout the state.
Thank you, Eric. Well, thank you. Are there any other committee questions? And I also just forgot to remind everyone at the beginning of this meeting that this is an open public meeting. So while committee members will be asking questions, especially regarding this presentation. If committee members have, or if anybody, members of the public have any questions, comments, please feel free to raise your hand, put them in the chat, or just come off mute. Feel free to participate to all who are part of this meeting. So just wanted to make sure everyone feels welcome to ask questions and put questions in the chat. So with that, I think if there are no other questions, I think we're ready to dive into the budget recommendations process that Eric just gave that overview of. So Sharon, do you want to sort of facilitate that? And I think we can just call people in the list that you have, and all committee members should have received the presentation materials as well. So I think we're good to go unless committee members have any questions about the process.
Okay,
And Sharon got a timer up, so I'll let you take that from there.
Yeah, thanks, Jesse. So we'll start and we'll just kind of go down the list. There are a couple people who wanted to support different presentations, so they should be on this list as well. So we'll stop and let them go. I have already informed all of the presenters that we need to try to keep it to 5 minutes. The list is kind of long, and we want to make sure everybody gets a good opportunity to make their presentations. But yes, all of the committee members should have all of the presentations and can ask questions after each presentation, and then they will be voting on their prioritization in the July meeting. So we will start off here with Michelle Brown, and I will pull up the presentations, and then when I turn it over, and then I'll just kind of start the clock. Sorry, I cannot get this clock any smaller. I tried. So if it blocks part of the presentations, everybody has these as well in your email. So, but if you didn't get them, let me know. So I will turn the time over to Michelle Brown. Thank you.
Thank you, Sharon. My name is Michelle Brown, and I am the CFO of Western Peak Specialty Hospital. I also have Jodelle Skinner here with me, and she is the Business Office Director. Can we go to the next slide? Our agenda today is to talk about the long-term acute reimbursement. The long-term acute care hospital is part of the skilled nursing facility state plan, and the skilled nursing facility based rate is part of the long-term acute care hospital reimbursement. We'll also talk about hospital price growth and what the outlook looks like for CMS as they measure growth moving in from 2019 to 2028. Next slide. To give you a little bit of an introduction for a long-term acute care hospital, we provide specialized complex care for patients with the same high level of care that they receive in an acute care hospital. We provide care for both adult and pediatric patients. We strive to provide children and their families with the finest pediatric specialty care, coupled with extensive family training in a therapeutic and supportive environment. Our close collaboration with Primary Children's Hospital allows a seamless transition for patients going from the NICU, PICU to our LTAC to home. Next slide, please. The long-term acute care per patient day reimbursement was established in 2018, and we've gone from 2018 to 2022 without any adjustment to reimbursement. Currently, our adult reimbursement per patient day is $1,293.95, and our pediatric is $1,419.70 per patient day. And the pediatric represents children 2 years and younger. And so from 2018 to 2022, we have not received a reimbursement increase. The skilled nursing facility state plan includes all long-term acute care hospitals. And part of the skilled nursing facility, a portion of the calculation for the base rate also went into the long-term acute care reimbursement when it was first established. So if we go and we look at the skilled nursing facility base rate from 2018, the base rate was $198.09. And in 2022, to be comparable, it was $261.71. So the skilled nursing facility has experienced a rate increase of 24% between 2018 and 2022, while the long-term acute care hospital has received 0. The reimbursement for LTACs, that rate was set in 2018 for both adults and pediatrics. Next slide. Looking to the American Hospital Association, an article that they published, they said within the health care field, hospitals and health systems have been leaders in controlling costs. Hospital price growth averaged 2% annually from 2010 until the beginning of the COVID pandemic. And next slide. And when we look to CMS and their guidelines from their article that they published in October 2021, they're saying the price growth of medical goods and services as measured by the personal health care deflator is projected to accelerate, averaging 2.4% per year for 2019 every year through 2028. This partially reflecting faster expected growth in healthcare sector wages. Next slide. At our hospital, Western Peak Specialty Hospital, we measured our own growth from 2019 to 2022. Patient care supplies increased 15%. From 2019 to 2022, direct care wages increased 20%. According to the American Hospital Association, some hospitals experienced wage increases as high as 132% from 2019 to current. Next slide, please. So what we would like to propose, the last increase was in 2018. We would like to propose an annual increase in this next budget session of a 3% increase for both pediatric adults, for pediatric and for the adult patients. And this is kind of just an overview of what that would look like in changing that reimbursement. Next slide, please. And then I kind of looked at the cost impact to Medicaid, taking the average patient days from 2019 to 2021, and came up with an average patient days for the pediatric patient and the adult patients. And next slide, please. And what it's looking like the impact will be at 3% for pediatric and adult combined. The total cost based on the average patient days for the last 3 years is a combined total of $113,563. Next slide, please. And in summary, we're just looking at the long-term acute care hospital. We're just looking to increase the reimbursement by 3% in the next budget year. And looking at, CMS is anticipating from the year 2019 to 2028 that the cost of healthcare goods and services will increase 2.4% annually. And Western Peak Specialty Hospital, our hospital, we have been experiencing an increase in cost and goods and services that exceed the 2.4% annual estimate by CMS. We would like you to consider annual increase to long-term acute care reimbursement. As looking at the skilled nursing facility and the state plan, the skilled nursing facilities are adjusted on a quarterly basis, and this has not been adjusted since 2018. Next slide, please. And does anyone have any questions?
This is Brian. I do. I had just one quick question in terms of the reimbursement or the increase that you got in 2018. Did you mention that? Did you say what percentage that was?
So the way it was working in the past is we would have to submit what's called a rate letter, and we'd have to calculate what our cost was. And so it was becoming very cumbersome for the state to calculate that for each patient, every single stay that the patient was in the facility for all of the long-term acute care hospitals. So they decided to take an average of the last 3 years for all of the long-term acute care hospitals and what that average reimbursement rate was. And that's what they established the rate in 2018 to be. But since then, nothing's been changed. We haven't experienced any kind of increase or any kind of acknowledgement or looking towards the cost increases that we've been experiencing over these last several years.
Thanks.
Okay, thank you, Michelle Brown, for that presentation.
Thanks.
Okay, so we are going to move on to Dr. Brooks.
Dorado Brooks here with Exact Sciences, Deputy Chief Medical Officer. I'm going to be talking today about how we feel that we can help improve screening for colorectal cancer in the Medicaid population. Next slide, please. So this is going to be a very quick overview of why colorectal cancer screening is important and the fact that screening rates are low in the Medicaid population, and this represents a missed opportunity to prevent colorectal cancer or find it early. Next slide, please. So screening rates in general are low across the U.S. It's estimated that 44 million 44 million individuals are not up to date with screening who should be screened. And this is going to result in 53,000 deaths from colorectal cancer this year. Next slide. The screening rates overall in the country, about 1 out of 3 people who are supposed to be screened are not up to date with screening. This map actually shows screening rates within federally qualified health centers, which take care of vulnerable populations in most states. We weren't able to find Utah-specific Medicaid screening rates, but we do know that a significant portion of Medicaid patients in Utah are cared for in these environments. And whereas about 1 out of 3 people are not up to date with screening in the average population in Utah, more than 70% of Utahns who should be screened, who are covered by in FQHCs, are not up to date with screening. Next slide, please. Screening recommendations have changed over the last couple of years, and where previously screening was recommended for every average risk person starting at age 50, now that has moved down to age 45. And that means that there are more individuals than ever who need to get caught up with screening. And this 45-year-old population is more likely to have Medicaid coverage. Next slide, please. There are multiple screening modalities that are recommended by all of the major screening guidelines, including visual exams like colonoscopy and stool tests. Next slide. And we know there's a significant body of evidence demonstrating that individuals who are offered choices are more likely to get screened. This study was actually done in a safety net population and found that for individuals who were offered a choice between stool testing and colonoscopy, more patients chose colonoscopy. If patients were simply told, go get a colonoscopy, only about 38% of them got screened. For individuals who were told, use these stool tests, and that was the only option, 67% got screened. So they were more likely to get screened if stool testing was offered, but in many settings, stool testing simply isn't offered. Next slide. So Cologuard is a breakthrough technology that uses 11 different DNA biomarkers to help identify patients who are more likely to have either cancer in their colon or precancerous lesions. It combines those biomarkers with a fecal immunochemical test. Next slide. And in the largest study to date looking at the performance of Cologuard, Cologuard found 92 cancers in patients who were subsequently found to have cancer at colonoscopy compared to, Cologuard found 92% of cancers, whereas FIT testing, simple fecal immunochemical testing, only found 74% of those cancers. Cologuard also did a better job at identifying precancers, finding 42% of those growths versus 24% of those that were found by by FIT testing. Next slide. It's also important to recognize that when a Cologuard is ordered, it is a program of services, not just a test, so that when Cologuard is shipped out The patient is contacted to make sure they understand why this test has been ordered for them and what the test is and how they're supposed to perform it. We then ship that kit directly to the patient, and then our lab contacts them to make sure that they understand how to collect the specimen. If we don't receive the specimen back within a certain period of time, we will reach out to patients and remind them. And this kind of navigation has been demonstrated in a lot of different environments to significantly increase the likelihood that patients will get screened. So we have a technology that is better than the standard fit testing, and we have a built-in patient adherence engine to help increase the likelihood that patients will get screened, and therefore we offer the opportunity to prevent cancer in ways that simply aren't available using only fit testing. I see I'm at the end of my time, and I'm wondering whether there are any questions and whether there are any barriers or impediments to including Cologuard in the Medicaid program in Utah.
Again, this is Brian. So you're saying that currently it's just not a Medicaid benefit then?
That is correct. Although it is recommended in all of the major guidelines.
Is Cologuard the only form of screening, or are there other ones? I'm sorry, are there other
Of the home
similar
test you're saying,
products?
Jesse? Yeah.
It's the only stool DNA-based approach. Fecal immunochemical testing, the FIT test that I mentioned, is also a test that can be done at home, but it has significantly lower sensitivity for cancer, and the adherence rates, the likelihood of patients following through, are much lower unless you've developed a program like we already have as part of Cologuard, and that's simply not part of FIT screening in most environments.
Hey, really quick, this is Tim Barr with Exact Sciences. I just wanted to point out too, this is a BIM model. I won't go into detail, but we did a customized BIM model for the state of Utah, and it showed that there would be no price difference, budget impact if we were to shift 15% utilization of Cologuard and take away about 15 combined utilization from colonoscopy and FIT FOBIT. And then in addition to that, I think Dr. Brooks mentioned that 90% of the Medicaid plans across the U.S. now offer Cologuard as a choice. So Utah is one of the remaining states that still does not offer this to Medicaid members.
Okay, so if there's no remaining questions, I thank you, Dr. Brooks, for your presentation.
All right, thanks for the chance to speak with you all. Take care.
Thank you. Okay, so we're going to move to BioReference Laboratories. Dr. Fernandez. And I've got two handouts here, so let me know if I'm on the wrong one. So thank you.
Good afternoon, everyone. I am Priscilla Fernandez. I'm the Reproductive Genetics Lab Director at BioReference Laboratories, and I have with me Dr. Tamara Packus, who's the Associate Chief Medical Officer at BioReference Labs. I don't really have a presentation, but I will go through an introduction and talk about the publications that we provided you, and maybe we can spend the rest of the time with question and answers. So we come to you today to seek coverage for non-invasive prenatal testing. Non-invasive prenatal testing as a clinical test has been around for a little over a decade. It really gained popularity as it replaced maternal serum screening due to its low rate of false positives compared to maternal serum screening. More recently, in 2020, the American College of Obstetrics and Gynecologists and the Society for Maternal Fetal Medicine recommended non-invasive prenatal testing as a choice that's appropriate for all pregnant women, regardless of their prior risk due to age. And this is a publication that we did provide you. I think it's the second one on this. So this is the bulletin. These are guidelines. These are highly recommended and followed by a lot of labs, both private payers, as well as a lot of the other states. So the whole utility clinical utility of non-invasive prenatal screening is to identify these women who can then go on to get genetic counseling and a diagnostic procedure. In the previous publication, Sharon, that you had pointed to, is a more recent study, which has a very nice picture, and I think it's on page 3 of this publication. It's a systematic evidence-based review conducted by the American College of Medical Genetics, which shows different centers. So you see it's a figure with bar charts, and if it's not on the 3rd or 4th page, yeah, right there. I don't know if we can magnify that, but this is just a study to show different centers that showed reduction in diagnostic procedures. So the way non-invasive prenatal screening works, it's a screening test, and so you have a positive finding or a screen positive finding, and those women then can opt for a diagnostic procedure like CVS or amnio, which would then confirm the findings from the screen. And what you're looking at here is that reduction of diagnostic tests because non-invasive prenatal screening is around and has gained popularity and is a safe test to do prior to opting for something diagnostic. And we all know amniocentesis and both CVS have certain risks of losing a fetus. And so this is a first step approach before you can consider diagnostic. But again, to keep in mind, this is a screening test. And so there is a possibility of a result that may not be indicated on diagnostic, or you can have a positive or false negative. But keeping that in mind, a lot of states are now offering this test. They have full coverage, and based on the guidelines, this is now available and covered not only for women who are advanced maternal age, but women who are at any age. With that in mind, BioReference Laboratories has 2 offerings for the screening test. So we have one that covers the major trisomies, T13, T18, T21, as well as the sex chromosome aneuploidies. And we have another offering where it includes both the sex chromosome aneuploidies, the common trisomies, as well as one of the microdeletions. And this is the 22q microdeletion. And the reason this was selected is among all of the microdeletions identified, this is the most prevalent one with an incidence of about 1 in 3,000 to 4,000. So here, again, we are looking for coverage for this test. We do have a specific requirement with seeking coverage. The way this test works on the platform that it is conducted on is an algorithm-based test. This algorithm is very specific and unique to the platform we use. So other labs doing non-invasive prenatal testing don't use an algorithm-based. But what this algorithm really does is it makes it very specific to the individual. So the expectant mom's maternal age at the time of the blood draw for the screen, as well as the age, the gestation age for a pregnancy, are taken into consideration to derive a score, which can then indicate that if the mom is screen positive or screen negative. Again, with a screening test, what's really important is sensitivity, specificity, and we have this platform that's based on numerous studies that have sound data on sensitivity and specificity. So that's what we are requesting coverage for. And since it's an algorithm, we were looking at the CPT code of 81507. That sets it apart from the others, which are not algorithm driven. With that, I will take any questions.
Thank you for that information, Priscilla. I'm Kim Danzy. Do you have a sense about how much expense would be created in the Medicaid program to offer the test?
I do not have information on that. I know we have other people who deal with that, Kyle or Patrick on the call. And can you just clarify that question, because I'm not very familiar with what exactly are you talking about, other peers in other states, or?
No, I guess my ask is just how much you expect this would cost the Medicaid program if they decided to offer the test.
I don't have that answer, but I can get back to you about it.
And can you just remind me? Oh, sorry, go ahead.
Oh, no, go ahead.
You said how many other states is this covers this?
I don't have the, gosh, I have to go back and.
Oh, that's okay.
We have about 18 states that have full coverage of a non-invasive prenatal screening, including DC, California, where prior authorization is not required, and both DC and California cover the specific algorithm-driven code 81507. I have an answer back, Kim, to your first question. 100% CMS, is that, or is that not the answer? I'm sorry, I don't deal with this space, so I don't know, and I don't know.
Okay, thank you. I didn't mean to put you on the spot.
No, but I will get back to you. I'm sorry about that. But yeah, we have other states that do cover it, and I think this is with Utah not covering it at all, and so many other states offering it, as well as for women of any age. I think this is a fair ask. You know what, when I was reviewing this paper and looking at the system-based evidence review, this really highlights the utility of, even though non-invasive prenatal screening is a screening test, it really reduces the number of diagnostic procedures, which in itself are expensive and come with risks to the patient. Any other questions?
Okay, thank you, Dr. Fernandez, for that presentation.
Thank you.
Okay, so next we have Allison Spangler, and she has 2 presentations each to present on. And so I will turn it over to you, and it's 5 minutes each. Allison, thank you so much.
Great, thank you. I appreciate everyone's time. I'm sorry you have to hear from me twice. I will try to make this very brief, but please feel free to ask any questions that you have. So the Utah Healthcare Association, for those of you that don't know, we are a nonprofit trade association, and we represent skilled nursing facilities, assisted living facilities, and intermediate care facilities for the intellectually disabled, which is who I'm representing for this first presentation. So these facilities our long-term care facilities for those with intellectual disabilities. Many have multiple diagnoses, not just intellectual disabilities. They require medical services, help with activities of daily living. Some are more medically complex. Some have more behavioral issues, and multiple other comorbidities along with their intellectual disability. Several years ago, the state mandated that these intermediate care facilities de-license as a whole 250 beds. This is to allow those that want to go into the community to transition out, which we fully support and are grateful that they're able to go and be out in the community and that they have those services. However, there are some residents still that not only want to live in an ICFID facility, but also need the services of that 24/7 nursing care and staff care and these support services that are provided in these facilities. Because of this delicensing of beds, this is less income ability for these facilities because they are no longer able to take, these licensed beds that they used to have. And coupling with rising costs, as we are seeing everywhere, workforce shortage is definitely hitting long-term care very hard, and they're having to be very competitive and increase their wages, along with other things such as their food costs, which have more than doubled in the last couple of years, along with gas prices and other things, to get the residents out in the community and teach them the life skills and programming that they're required to participate in as they're regulated by CMS. I have this handout here. You can scroll down, please. I won't go over it too much. You have it in your packet, but just this kind of goes over roughly what we've talked about, how we've had to de-license bed and how there's been rising costs. Over the last few years, we've been able to get one-time money for a quality incentive program for these intermediate care facilities. This program this last year was funded one time at $900,000. So we are asking to be prioritized in the budget for that $900,000 for these facilities. This quality incentive program includes things like programming, vocational rehab, life skills, also some education for the staff, and a few other things to allow these facilities to show that they are using this money towards quality of care for the residents living in these facilities. We have also talked as a group and are committed to adding another category to this quality incentive program, just to show our dedication to use this money towards the purpose of improving and increasing the quality of care for these residents. We'd love to see another category in this program centered around self-administration of medication for these residents. So again, this is a program that we've received one-time money for over the last several years, but we would love to see it ongoing, so we're not having to come back and beg for this money every year. It's definitely something that they need with the rising costs and less income ability, and they still have that same overhead. Their building size hasn't changed, but their license and income ability has. So with that, I'll open it up to any questions. I know I talked really fast, but wanted to get all that in there. So please feel free to ask any questions that you might have.
Okay, and if there's no questions on that presentation, if you want to move on to your next one, and maybe they have questions for both. Thanks.
Sure, yeah, no problem. Please feel free to think about it. So for this one, I'm switching gears to our Utah Center for Assisted Living, part of the Utah Healthcare Association, where we represent the assisted living facilities. And here I'm asking for a rate increase for the New Choices Waiver Program. It has been around since around 2004, 2005, and there has not been a rate increase since. And as we all know, the cost of living has increased exponentially, not only in the last couple of years, but in the last 17 years. As you can see here on this handout that I provided to you, we were able to survey around 94 out of the 250-ish assisted living facilities in the state. And 83 of those are able to accept the New Choices Waiver and are approved for that program. However, as we really got to the details of those that can accept, the majority are either turning away these residents or reducing the amount that they are taking in their facility because the costs to care for them, it is just too much. They cannot afford to at the rate that they are receiving. They are currently receiving a rate of $69.75 a day for assisted living residents and $82.60 a day for memory care residents. As you can see here, 77% have considered reducing, and most of them, their costs have doubled, if not tripled, in workforce, which is where this new choice waiver assists them. The resident still has to pay for their room and board and their other costs, and unfortunately, with the increase in cost, most of them aren't even able to pay for that room and board. So it's just not financially feasible for these assisted living facilities to care for these residents anymore. And it's a great, they want to continue this great service for the residents of Utah and for these vulnerable older adults that need this care. And it's definitely a cost savings to the state to be able to care for them in this level of living. I mean, they would love to continue to do so, but with a reasonable rate increase. We would love to see this rate increase to so $69.75 is the assisted living. We are proposing taking that to $105. And then the memory care was at $82.60, and we are proposing that at $125. And if you take into account the cost of living adjustment, these are actually right in line and actually just a few dollars less than what it would be if you were to take that increase year over year. Like you can see here, their staff wages have doubled since 2005. Again, to be competitive with hospitals, with any other industry, we're having to increase our wages, and we want to be able to retain these staff, but it's very difficult with the limited budgets, and a majority of them are losing money on these new choices waiver residents. And that's all I really have here for this presentation. Happy to take any questions on this proposal. And I guess just to add, lastly, a lot of these residents that are on this Medicaid waiver program are a lot more complex care and have more behaviors. So the services that they're needing to provide, just their care level, definitely outweighs the rate that they're currently getting.
Okay, well, thank you, Allison, for that presentation. I'm not hearing any questions, but if anybody has any, please speak up. Okay. All right, we will go to our next presenter, Lisa Thornton, on family caregiver compensation. Go ahead and take it away, Lisa.
I'm Lisa Thornton, and I'm here with Annalie Smith, and we are both advocates and mothers with children on the waiver. We are here asking this committee to prioritize the request that parent caregiver compensation be made permanent and ongoing, which is the $5,150,000 that was included in the governor's budget and appropriated by the legislature for fiscal year 2023. During 2020, 10% of parents of DSPD home and community-based services waiver of individuals 18 and older opted for caregiver compensation allowed under Appendix K. Parents received on average $593 a week for providing extraordinary care during this time. The last 2 years have shown parent and guardian caregiver compensation is a feasible and much needed option, and it should be made permanent. Early indications also show improved quality of care for Medicaid clients. We've built a strong coalition in support of making parent caregiver compensation permanent, consisting of members you see in your handout under the background section, and Angie Pina of DSPD and Tanya Hales of Medicaid are participating as resources to the coalition. Permanent parent caregiver compensation would provide many benefits. First, many parents are unable to place their child in residential and day programs as their children are too severe medically and/or behaviorally. Further, some parents would prefer to provide care and keep their child with them rather than have them in a residential placement, but they cannot afford to leave their regularly paying jobs. Parent caregiver compensation allows parents to stay home, provide optimum care for their child, provide financial resources directly to the family, and keep the family model intact. Angela Rasmussen of Salt Lake City reports because of caregiver compensation, she was able to keep her 18-year-old son with severe disabilities in her home rather than use a residential placement. Megan Croft from Eagle Mountain states, being paid during this time of caregiver compensation has literally helped me put food on my table and a roof over our heads. I am by far the most qualified person to take care of my 18-year-old daughter, and I have the desire to be the one helping her. Number two, being parent caregiver compensation saves the state significant funds. $593 a week is a fraction of the cost of a residential or skilled nursing placement. Number three, parent caregiver compensation helps fill the gap in services. Presently, there exists a shortage of care providers and a high turnover rate. Parents, through caregiver compensation, are gladly stepping into the caregiver role with a 0% turnover rate. We show up every day and provide high quality care. Annalie, are you there? I'll start talking and she can chime in. Caregiver compensation may reduce overall costs for behavior and mental health interventions and medical care as the parents, rather than rotating staff, provide that care. Consistency of care makes a positive, significant difference for the individual on the waiver. Are you there, Annalie? So Annalie, she says, being a paid caregiver allows me to be with our 6 foot, 200-pound son with severe autism and cognitive impairment. If our son is managed very consistently and carefully, he is much calmer and most of the self-harming and aggressive behaviors can be avoided.
I think I'm here now. Sorry, I couldn't figure out how to unmute. I'm not familiar with this Google Meet. My apologies for that. So my son needs a lot of consistency to manage self-harming and aggressive behaviors. But being with him during the time that a caregiver compensation was allowed resulted in him not only being safer, but also calmer and happier. And we were able to reduce his behavioral supports and his psychotropic medications because there was more consistency of care. Also, Pam, a mother from Tooele, had the same experience with her 23-year-old daughter, who was able to go off 2 different anxiety medications. And because of the consistency of care with her mother, and her doctor had commented on how much more content her daughter seemed. Lisa's daughter, Kate, would run away from staff several times in a given week. But while Lisa was providing the care under caregiver compensation, Kate ran away only once in 2 years. Kimberly Garrard reports that through caregiver compensation, she is able to attend all of her doctor appointments with her children on the waiver, and she gets a better idea of their complex medical needs, and she's been able to see improvement in their chronic illnesses, and they've made good progress on their individual goals. So number 5 is that parent guardian compensation removes the unfair burden on siblings, often young siblings at home, who have to fill the gap and provide care for siblings with severe medical and behavior issues while their parents work. Utah sibling studies show clinically significant symptoms of PTSD in 59% of these siblings. Diana Sackett, as a recipient of caregiver compensation, sums up well the benefits. Honestly, having a choice in who cares for our child in their most intimate settings and being able to do so well and not compromising care has been an amazing experience. Our home feels more like our home instead of a workplace with rotating staff coming in and out. Thank you.
Do you have any questions?
Thank you for your presentation. I probably asked this question too much, but do you know if any other states are, will be extending this one-time funding, if this will be something that continues in other states? So I agree, it is so important.
There are about 26 states that provide this. Several more joined during the pandemic under Appendix K, but there were 26 states that were providing this even before the pandemic. So it's very well known and done throughout the country because it works.
Okay, and we also have Alan Ormsby. He wanted to speak for just a few minutes to give his support to this. So Alan.
Yeah, thank you. Thank you very much. Alan Ormsby, and on behalf of AARP and our 224,000 members, I want to thank you for the opportunity to go on the record to support the Caregiver Compensation Program. AARP worked with Senator Harper and Representative Daley Provo to pass SB 63 in 2021, and it's authorized the state to compensate caregivers who provide extraordinary care. The legislature saw the value in this program and funded it with an ongoing appropriation. Since that time, the department has expanded the program to cover other types of caregivers, including parents and guardians, but it has been funded incrementally with just one-time funding, including in this last legislative session when the legislature funded the expansion program with a one-time funding of $5,150,000. Today, we're asking for your support to make this funding ongoing. As members of the committee, you know the struggle many long-term care providers are facing to find sufficient staffing. The quality of care for vulnerable Utahns suffers when they can't receive the attention they need. You've heard today stories about how the same people are receiving better care sometimes from their family members as a part of this program. Those who know them best, see them most regularly, and are most concerned about their welfare are often best suited to provide them care. It also helps keep more families intact instead of having to place loved ones in institutional settings, and those institutional settings cost more to the Medicaid system. At a time when we have severe staffing shortages, we can't afford to ignore this workforce who is providing quality care for such a low cost. In fact, this program should be a model for how better to support even more family caregivers to relieve stresses that exist in our healthcare system. Thank you for the opportunity to go on the record, and I'd be happy to answer questions if there are any.
Okay, so I'm not hearing any questions. So thank you so much, Lisa Thornton and Alan Ormsby, for your presentation. Okay, so next we will go to Don Clayback.
Thank you, Sharon. And you don't have to scroll through everything. If you want, if you can keep the pictorial up, I think that'll be fine. Appreciate that. Thank you for this opportunity. My name is Don Clayback. I'm Executive Director of NCARB, which is a national association of manufacturers and local providers of what we call complex rehab technology. These are products, manual and power wheelchairs, seating systems, and also other adaptive equipment like standing devices and gait trainers that are used by children and adults with high-level disabilities. So it's a small niche, if you will. There's a small network of providers, and we have three requests that I'll share as I share my comments with you. But I did want to just talk a little bit about the environment that we're currently operating in. Complex rehab technology is a very challenging business because our customers require a lot of customization of their equipment. It's very service intensive. The products are very specialized, and they're provided through really a team of both the clinical folks, the physicians, the occupational therapists, the physical therapists, along with the supplier who has the equipment specialists, the technology experts. And what they do is they work with the individual and many times their family to develop the right mix of technology that is going to maximize the person's independence and function, and also play a significant role in reducing their cost of healthcare. Medical interventions, institutionalization, caregiver needs, all those really can be dramatically impacted if people get the right technology. The challenge, though, is that there's only a small number of companies that are currently providing this. that number has dropped significantly over the past 10 years because, frankly, of the challenges in terms of operating the business, meeting their customer needs, and dealing with the funding challenges and the sometimes inadequate payment amounts that relate to these items. This is particularly true for the last 2 years. As we all know, all facilities have been dealing with the pandemic issues, but it particularly hits these companies. Over 90% of the services that these companies provide are provided in the home, at the school, or at another facility. So there's a lot of time and expense that goes into providing this equipment. And it really is important because these folks have very specific needs, and the equipment has to be customized to meet their needs, not only now, but in the future. But the expenses that companies have been incurring these past 2 years, increase in product cost, increase in payroll cost, shipping, getting these products in, and then also the distribution and delivery cost, as we're all familiar with the increase in gas and other vehicle expenses, have hit these companies particularly hard. And so what we're trying to do is make sure that there's an environment that these providers can continue to provide these needed services to the people that need the equipment and their family members. So this diagnosis like spinal cord injury, traumatic brain injury, cerebral palsy, muscular dystrophy, ALS, these are the folks that require this equipment. And it's, again, a small population, but the needs are very high. And so the companies have to have the resources to meet those needs, not only in getting them the right equipment, but also in getting them providing that service ongoing. So we have 3 requests that we're looking for. One, and we've been working with the department on these issues. One is for the repair of these items, that there's the labor that's involved is fully covered. There are certain items right now that the labor is not being provided for or covered, and that needs to be paid for so services could be provided. There's one of the codes, the billing codes that are used for items that aren't classified under the traditional billing codes. That's paid right now under a cost plus system. That payment rate isn't sufficient for many of these items. So we're looking for the state to change that to a list price, a discount off list price. And finally, we have the Medicare payment rates. Medicare sets up a particular modifier for certain of these specialized items. And we're looking for the state to adopt that Medicare payment rate so that the proper payment amounts can be allowed again for these more customized items. So again, we're working with the department. We appreciate the committee looking at our proposal, and we would definitely like your support in prioritizing this as the state works on the budget. So happy to answer any questions or provide additional information.
This is Brian. Quick question. A lot of this stuff goes through like the local DME agencies as well, right? The companies there.
Well, and Brian, not these items. There's a lot of DME companies in town, and they provide important services, but there really are only 6 organizations really across the state that are providing this more complex technology. So, you know, a lot of companies provide the basic wheelchairs and hospital beds, but this technology, because it's so specialized, and you have to have really a particular group of staff and infrastructure, it's a very small network of companies that provide it.
Right. Okay. Yep. Thank you.
Sure.
Okay, so if we don't have any other questions, thank you, Don Clayback, for that presentation. We
Thank you.
appreciate it. Thanks. Okay, next we have Matt Hansen regarding Medicaid rates for home care, and then we've got several people who would like to speak in support of that after Matt Hansen and Chris Dobson's presentation.
Thank you,
So-
Sharon. I appreciate that. And I appreciate the opportunity that the committee has given us to be able to talk about a couple different topics here. Allie Spengler, I think, forgot she talked fast because she wanted to give us the remaining time on the clock. So I appreciate that, Allie. We actually, I do want to say that we're very supportive of Allie's request also in the new choices waiver. One of our requests is related to the new choices waiver as well, but from the home care side, we're also supportive of the parent and caregiver compensation, which is something that we've spoken for in the past. I am the executive director for the Home Care and Hospice Association of Utah. And in 2019, and with the support of the Utah State Legislature, we experienced our first Medicaid or general Medicaid increase to our rates in 14 years. That increase occurred at a critical time when many of our providers were having to make difficult decisions, to reduce the number of Medicaid members that they could serve or stop accepting Medicaid altogether. Since that time, we've been working with the Department of Health and Human Services and others to standardize the rate review and request process for Medicaid providers. And though progress is being made, again, many agencies are finding themselves in a difficult situation where they have to make a decision due to the crushing inflationary pressures and ongoing healthcare staffing crisis that other presenters have alluded to. All these factors are driving the cost of labor and the cost of business higher at alarming rates. Still, home care continues to be the most efficient solution for the healthcare system and a preferred choice for payers. I should know that even though we experienced a desperately needed rate increase just over 3 years ago, some of that money for personal care services was taken back and redistributed with other Medicaid providers because CMS wanted to know why one industry had a single year increase that was so significant compared to other industries. In short, it was because we hadn't had an increase in over a decade. Our request is that the MAC recommend another general reimbursement rate increase for Medicaid home care services. The most pressing need is for an increase of 15% to the significantly depressed waiver program reimbursement rates, particularly those for the new choice waiver and the aging waiver programs, whose beneficiaries are more dependent on our industry for care. We still consider, even though that seems significant, 15%, we still consider it a Band-Aid, but it's kind of an emergency solution so that we can get through another year and see what happens, with inflation, gas prices, et cetera. Both of these codes currently reimburse at just $5.32 per 15 minutes for personal care. That's $21.27 per hour. So as you can imagine, anyone still providing the services is doing so at a loss, with the fully loaded hourly cost of a caregiver being more than the reimbursement rate. On top of that, they have all the other costs, overhead, gas prices that have doubled in the last year. And that's something that's unique to our industry, or somewhat unique. I say we're more exposed. And then the staffing crisis. And then our second part of request, and though it's insufficient as a long-term solution, we're also asking for an increase of 3 to 5% for home care reimbursement rates, particularly to the home health aid, nursing, and physical therapy rates in order of priority. We believe that if approved, our request would help to bridge the gap as we continue to work for a long-term solution for rate reviews. Without the increase, we're concerned that it'll soon lead to increased interruption of services and waiting lists as more providers discontinue services or reduce the number of Medicaid members that are able to serve. So I want to thank you for your time. I'll be available for questions in a moment, but I'd like to concede the rest of my time to Chris Dobson, who's our personal care chair. Chris, are you on?
Yes, I am here. Thank you, Matt. Everything that Matt said is true. Allison and Lisa, both the waivers, it's a critical time. One thing that sets home care a little bit apart is that through Department of Labor law, we are required to pay travel time and mileage before the caregiver even gets there to start the job. So if you're in there for an hour or two, you have to also absorb 20, 30, 45 minutes, an hour of a caregiver's time into the time you have to actually bill. So a lot of people are thinking like, well, what's an hourly wage of a caregiver to do this time of work? You have to factor in, we're dealing with the travel time as well too. So we have inflated costs. Margins are not tight. Margins are negative. We are paying money to take care of these people on the waiver programs. Most people are not taking new clients. In 2020, we had 42. We now have 25. And that's because I'm not going to discharge someone we've been taking care of because of reimbursement. But I'm also not going to take a new client that I have to pay money to take care of. It's so hard to hire right now. And when you hire people and you're staffing people that you're losing money on instead of others, you're in a bad position. Sorry. Open for questions.
Thank you, Chris. Sorry I didn't leave you a little bit more time on the clock. Any questions from the group for us?
Hey, Matt, I'm just wondering, and this isn't meant to, so if we can always, you can bring additional information another time too, but how does this in caregiver, family or parent caregiver, how, I know there's support for both these requests, but how do you see them interacting?
Great question. Thank you. I think by there being compensation for parent and caregivers, that it provides another opportunity for these individuals, right? The New Choices program gives individuals an opportunity to be in an integrated community-based setting. They have more support if they have family that is able, and many of these families, the sad thing is they're going to be at home with their loved one anyway. So many of them have had to leave work, and don't have an opportunity to work. But it gives opportunity for those that could make a choice between the two of them. And being in the staffing crisis that we are, you think a lot of people have asked us the same question. They say, well, aren't your members, opposed to having family caregivers paid because then it reduces the demand for their services? Absolutely not. We've talked about this as a group a lot, and we feel that when family is paid, they're there, and as was mentioned, they know their loved one better than anybody. We're here to be a supplement and a support to the family and to the individual. But also, we feel that it's only going to help to support our need right now as well. Because if it's not, the services aren't provided by family members, we have to provide them, and we may not have the staff to be able to do it.
And there's not a family member. I prefer that. We don't see people who have that as an option. If they had family and stuff who were there and could do the job, then we wouldn't be in the house. Same type of care, just different situations and demographics that people are trying to take care of.
Thanks, Jesse. Great question.
So do we want to move to Brent Jones, Dave Park, and Bo Sorensen, who wants to speak on behalf?
Thank you. My name is Brent Jones. I'm the president and CEO of CNS Home Health and Hospice. And just to echo also some of the comments that have been made, we appreciated the increase in 2019, but because of escalating costs, as you've been hearing already through your presentations today, our home health aides in particular have went up. Our costs for them have went up 24% in our cost of just to provide care, just the basics of care. And our cost for our nurses has went up 26%. And so we were already lower under, for proper Medicaid reimbursement. This just magnifies the problem and the shortfall that we have. So Matt's request for the 3% from myself as a nonprofit. We also provide a lot of non-charitable care. We do that obviously through our grant program, charitable program. But the request that Matt asked for, that 3 or 4%, I obviously fully support, so we can help continue to provide for the Medicaid patients in the state of Utah. So thank you.
This is Dave Park. Can you hear me? Okay, good. I'm Dave Park, and I'm the president and CEO of Home Instead here in Salt Lake. Again, just to echo what everyone's saying, you're hearing a lot about waivers. And personal care agencies like Home Instead, we have 6 offices in Utah, service hundreds and hundreds of people. Some of the offices, like my office that I opened 12 years ago, we had been doing a lot of Medicaid because the territory that we cover, sometimes people can't privately pay to have care come in. And so we've been doing the waiver program for years. Up until, like Matt said, up until 2018, when we had come to these MAC meetings or other Medicaid meetings, we were always told the only way that rates are going to change is if you go to the legislature and lobby for changes. And so we did that. Matt Hansen led the charge in doing that. We were able to successfully get a bill passed, which significantly raised our rates. And then 1 year to the day later, July 1st of 2020, our reimbursements just dropped out again. And we went back later and found out that Medicaid had done an assessment to equalize, I guess, the different programs on Medicaid. So the monies that we had finally got approved were taken away, and only a small amount were coming back. Let me share some specific examples. Like with respite care, we do a lot of respite care. Prior to 2018, the rate was $22.58. With the rate increase in 2019, it went to $28.03. And so we started picking up a lot of these clients, and it was working. 1 year later, it dropped down, not to $22.58, but down to $22.56. So today it's actually 2 cents less than it was before we even got a rate increase. The attendant care is one of the main ones that we always bill. It's S5125. The rates continue to be 2127. And homemaking, which is some of the people depend on us to do their grocery shopping and all of them prepare their meals and things like that. Prior to 2018, it was $24.50. We had the rate increase, went up to $30.69. And then it dropped down to $24.87 1 year later. So that rate increase that we kind of fought for literally just kind of evaporated. I think Matt was being politically correct when he said, some of it went away. Most of it went away. So now here we are again, coming back to the MAC and saying, please help us, because like Chris Dobson was saying, and the cost for having caregivers going to the home is significant. 12 years ago, my average pay was between $10 and $12. Now it's between $13 and $18. I used to bill privately 12 years ago, $16.95 an hour. Now our rates are over $30 with minimums, meaning they have to be doing 9 to 12 hours a week. And if not, the rate goes up to $45 an hour. So from a private pay standpoint, our rates have just gone through the roof because we've had to pay our caregivers significantly more. Most of the codes that we bill, like Chris Dobson and Matt have said, we literally lose money on. I lose a couple of bucks every single hour that I do New Choices waiver. A year and a half ago, I had over 100 patients that we were caring for in their homes at Medicaid. Now I'm closer to 40. Because I just can't bring on more. I have, and I know it's not good business sense, but over the last few months, I have brought on a few more because case managers have begged me to, but we're bringing them on at a loss. One of them in Tooele, a gentleman that was quadriplegic, we couldn't fill all the hours. I just couldn't pay enough to keep it filled. He's back in a skilled nursing facility, and I doubt he'll be coming back home again. Because Salt Lake County Aging Services is so persuasive, they twisted my arm to pick up a couple of clients through the aging waiver program, and their reimbursement rate for those codes is $18 an hour. So I'm just losing money hand over fist when it comes to those two new people we brought on. And another lady that we just brought on 2 weeks ago, maybe, she's also a quad. She was not able to get staffing through other agencies. She came to us. It took us 2 weeks to prep to get on there. She went 4 days without care. So the other agency had ended. We didn't have the staffing yet to start her up. And now we've been servicing her for a couple of weeks, but she went, and this is a quad that can't get out of bed. So she had to have family, church, neighbors come over and help her for a few days just to get her brief changed, to go to the bathroom. It's not going in a good direction, and I really want to be able to bring on more Medicaid people, but I like I say, I either have to run my business in the ground to be a considerate member of society, or I have to keep the business going and just let these people go without care, and they need to be home. So anyway, that's a lot of other things that I could share, but it really is at that point where it's critical. It's critical that we have something happen. So thank you.
And thank you. My name is Bo Sorensen with First Choice Home Health and Hospice. I'm the COO and one of the owners. And I don't want to take too much of your time. I know that a lot of what I would say is just reiterating what Matt and Chris and Dave and Brent have already said. But I do just want to discuss a little bit about the caregiver hours and reiterate what Chris was saying about how even though you think that you're just paying for an hour, you're actually like, we may be getting reimbursed an hour, but we're actually paying for anywhere from an hour and 15 to an hour and 30 minutes per visit that we go out and see one of these folks. And in terms of the inflation for direct wages, we've seen inflation sometimes it's been up to 35 to 45% for some of our aides. And a big part of that is because we're now competing with fast food and other industries where they used to be lower priced, where they are now the same price or even higher than what we were paying our aides. And so as a result, people are going into easier job fields and saying, well, I don't want to go drive around all day and take care of people. I just want something that's easy that I don't have to worry about. So we have to pay a premium to those rates in order to attract talent and in order to fill some of the spots that we have. And so as a result, you look at the rate sheet that Matt provided you, and under the personal care agency's story and their fully loaded cost of $22.99, we're seeing a fully loaded cost in some cases. We're seeing a actual wage rate of about $19 an hour for a typical person, and when you factor in travel and things like that, just for the individual themselves, it can get upwards of $24, $25 for that $21.27 that we're receiving from the New Choices waiver. And so it is crucial for us to be able to get some kind of increase, preferably the 15% that Matt talked about, in order to keep this program afloat and be able to keep folks in their home and hopefully keep them from higher cost care locations. So I know that you've taken a lot of time for us, and I do appreciate that. And I don't know if you have any questions for Brent or Dave or I, but we'd be happy to answer them, or happy to let you all move on to the next group.
If I could just share both, since you were so bold and shared your fully loaded cost with all of your competitors listening like me, I can tell you that my fully loaded cost is $24.14.
Okay.
That's the cost it is. So it's right in line with what you're at. And that's why doing most of my codes at $21.27 is killing me. And some of them at 18. I'm just begging to stay in business with Medicaid. There's over 100 personal care agencies in Utah. Most don't do any Medicaid. It's all private pay. And for those of us that do private pay, if they're part of an ACO, which they all have closed panels, but if you are part of an ACO, you can bill for some codes that pay okay. But if you're only doing waivers, every hour is a loss. And unfortunately, home instead is only a waiver. We can't get on any panels. And so I've got to make some decisions pretty quick of what to do. And I'm not the only one. So anyway, sorry. Thanks, Bo.
Okay, thank you everybody for those presentations. We appreciate it. Keeping the momentum going, let's go to Jesse. You're next on our list here. Thanks, Jesse.
Thanks, Sharon. Yeah, I'll just thank you all for everybody that's presented so far. I just want to just appreciate everybody for making the time and space to present. Sharon, I'll be brief, and I do just want to point out there's another handout. You don't need to put it up, but just for committee members to be aware of as well, which I'll refer to. But I'm Jesse. I'm in addition to chairing the MCAC, I'm also with Voices for Utah Children, and I'm here today to present on a funding request, a joint funding request that many of you are familiar with, many committee members, members of the public over the years, but remains incredibly critical. And with the anticipated unwinding of the public health emergency, I believe is now especially urgent. And this request is to cover all Utah children, to help all Utah children access consistent health coverage. And specifically, this request would address two critical items that would assure that all Utah children would have access to affordable health insurance. The first would be coverage for all income eligible children, regardless of immigration status. The second would be 12-month continuous eligibility for children enrolled in Medicaid. So assuring that no child is denied coverage because of their immigration or citizenship status, and that all children enrolled in Medicaid have guaranteed stable coverage for 1 year, just like they do in CHIP, just like they do in the private insurance market. Together, those two policies would make a huge difference for Utah children and change the trajectory for Utah children's coverage. So heading into the pandemic, a few facts that I want to flag right now. One is that Utah had one of the highest rates of uninsured children in the nation. I know many of you are aware of this, but it's still incredibly important to lift up. We had 82,000 uninsured children in the nation, ranked 46th when it came to insuring kids. Our numbers have changed quite a bit over the course of the pandemic because of provisions like continuous coverage, but we know when the public health emergency ends, our kids are going to be at risk of losing coverage. We had one of the highest rates of uninsured Latinx or Hispanic children in the nation, and we also have the highest rate of uninsured children who were currently eligible for programs like Medicaid and CHIP but not enrolled. These two provisions, continuous eligibility and coverage for all children, regardless of immigration status, will be that welcome mat so that children are guaranteed stable, continuous coverage. We know that there are so many children out there who are eligible right now, many in mixed status families who may have a sibling who is eligible, but one who is not, and causing parents to have to make painful decisions about how to proceed with their children's health coverage. Children's health coverage is foundational for children's success. And I know many of you are familiar with these facts, but I think they bear worth repeating. Of course, insurance doesn't guarantee, but it's the price to admission, as some people say. Without health insurance, then we are already doing a disservice to our kids. Children have better short and long-term health outcomes when they are insured. It's shown through decades of research, they have better academic achievements. They miss fewer days of school. And then as adults, they go on to have improved economic stability and even earn higher income as adults. So there are ripple effects. And by not insuring children now, we are doing a disservice to our kids and families now and in the future. It's time that we assure all children have guaranteed coverage for 1 year and that no child is denied coverage because of their background, that all income eligible children are eligible, can enroll in Medicaid and CHIP. I'm attaching to this document, you'll see some of the cost estimates that we put together that are aligned with the fiscal, the fiscal estimates as well. And one item that I didn't include that I'm happy to follow up with anyone that would be interested is that in addition to the cost estimates, we also know there's significant cost savings to our state if we cover all kids. There's been research done that's shown that over $9 million in public state dollars would be saved covering all kids. So of course there's cost savings, significant cost savings that come with covering all kids. But I'm asking this committee today to please consider and prioritize funding because we know that our kids deserve the opportunity to get covered, to be healthy, and to thrive. And with the end of the public health emergency coming up, we have the opportunity to put in place proactive measures that will do just that won't set us back, but will actually move kids' coverage forward. So, thank you very much.
Okay, are there any questions for Jessie? Okay, not hearing any questions.
I have a question.
Sure.
Jessie, I know that this has been really favorably received in many legislative sessions. What has been the reason people haven't moved on this previously?
Yeah, there's been, this was in the legislative session this past year and the year before, and it received broad support in the Senate. But because of timing, it did not receive a vote in the House. Representative Mike Schultz was the House sponsor, but it didn't get a time to have a vote. But it did receive broad support in the Senate and did pass out of the Senate. 1 year was Health and Human Services Committee, and 1 year was actually Tax and Revenue Committee. Thanks.
Okay, thanks you, Jessie. Next, so Jessica, you asked the question here, and there was a little bit of misunderstanding. I think, Jessica, you've got two presentations that you would like to do. One is family planning and one is postpartum. So if you want to go ahead on both and tell me which one you want to
So I'm actually just going to present on the family planning amendment, and then have Gabe present on the postpartum and pregnancy level changes together because they really do go very well hand in hand, if that's okay.
Okay, yep, sounds good. So thank
Okay,
you.
excellent. And sorry again for the confusion, and thank you
That's
for
okay.
the opportunity to present. So my name is Jessica Sanders, and I'm the Director of Family Planning Research at the Ascent Center for Sexual and Reproductive Health Research and Policy. And today I'm presenting on an evidence-based Medicaid program modification that will benefit thousands of Utahns that are currently unable to access family planning services and contraceptive care. So this recommendation for prioritization also comes on the tail of a 3-year statewide demonstration project where we found that individuals who were falling through these coverage gaps were able to access more effective methods of contraception, and including going from none to a method of contraception with cost barriers were removed. So family planning services support people in having the healthiest pregnancies when they're ready and reduces the number of people in need of abortion. In light of the 2020 Senate Bill 174 and the likely Supreme Court decision to overturn Roe versus Wade, access to contraceptive care in Utah will become even more important. So beyond pregnancy prevention, contraceptive methods are also used to treat a range of medical conditions that have substantial impact on quality of life, and are used by 99% of, or have been used by 99% of people of reproductive age at some point in their lives. So really do benefit everyone. Covering family planning is also economically sound. This program would cover individuals who are falling through the coverage gap with family planning specific coverage based on income eligibility of less than 250% federal poverty. And this can be done through a waiver or a state plan amendment, which have already been pre-approved and receive an ongoing 90-10 federal match. So based on a fiscal analysis from last year, there's also indications that this program would bring an additional, significant additional federal funds into the program, and may cost the state around $560,000 in general funds a year. So it's a relatively low investment for high reward. The nationally 26 states have expanded Medicaid for family planning services. And this includes many states that provide coverage for men and women, individuals younger than 19 years of age, and many states who have switched from waivers to state plan amendments to keep them ongoing because it is demonstrated. With the flyer that we're scrolling through, I guess I should have used that as the main presentation point, but the family planning services do have a return on investment for about $7 for every public dollar spent, and have been shown to increase post-secondary education and employment, increase individual earnings, and fewer people accessing Medicaid services later. So this can be, and that would be by way of preventing unwanted or unplanned pregnancies. So estimates show that this program would save the state about $13 million or $12.7 million in healthcare related cost. Yeah, so I think that's kind of the gist of this program, and I think that certainly as we move forward in the national landscape of contraceptive care and supporting people of reproductive age and with the capacity to become pregnant becomes more essential, and is certainly in line with Utah values of supporting families and children and parents. So, thanks. I'd love to answer any questions.
So Gina Tuttle, do you have a question?
Hey Jessica, I have here at the Wasatch County Health Department, I have my own family planning clinic, and we do see a few Medicaid clients right now. How is this going to increase how much providers are going to receive from Medicaid? I mean, how is this going to improve the current payment? And are they going to have any more services that are going to be added since there's already current services through Medicaid?
So The way that this program would be set up or could be set up is that it would become, it would increase the number of individuals who are eligible for coverage for family planning services. So there's no renegotiation of reimbursement at this juncture, but certainly for folks who are unable to access services would allow them to be to receive the care and could be seen at any in any clinic that accepts Medicaid.
That's cool. How are they going to determine the women that they can increase the numbers on? I mean, do you understand my question? If you meet Medicaid guidelines and you're on Medicaid, that's one thing. But what if you make a little bit too much? Is that what you're looking for?
Yeah, so this would increase eligibility up to 250% federal poverty, which at a national level has kind of been determined the range of folks who need access to publicly funded family planning services. Most states operate under presumptive eligibility, so allow for people to access services in the clinic to receive reimbursement while folks' applications for Medicaid are going through, or if they believe that they are eligible under traditional Medicaid, but would cover solely based on income up to 250% federal poverty.
Oh, that's great. Okay.
Yeah. So it hopefully would simplify the process too. With the Family Planning Elevated Program demonstration project that we did, that was one of the main barriers to accessing care, was the application process. Even for folks
I was in the pilot program for the Family Planning Elevated, so I understand that program.
Yeah, that's awesome. And thank you for all that you did for folks over the last few years. And that program is coming to a close. And so it's also, we've demonstrated thousands of people in need of these services that were able to access that. And clinics who really were able to provide care that they wanted to provide. And so we've seen the need and hoping that Medicaid can pick up where this program left off. Thank you.
Okay, thanks, Jessica. Stephanie Burdick, are you on? And I don't have a presentation or a handout for Stephanie's.
Hi, Sharon.
Hi.
Yes, I'm on.
Hey.
I did not prepare a presentation, everyone. I apologize, but I will try to be quick. I know that, I know that everyone's been listening for a while. So for those of y'all who that I don't know, my name is Stephanie Burdick, and I am a member of the MAC, and I'm also a Medicaid member. And I wanted to talk a little bit today about community health workers and why I'm asking all of you and asking the state to prioritize funding for community health workers for members in the Medicaid population. I know a lot of you are aware that the burden of disease and healthcare complexity is not equally distributed. I'm sure many of you have heard the statistics and the data that tells us that a small 5% or so of the US population account for 50% of healthcare spending. And research into this population tells us that those who have a serious health condition and social barrier and or behavioral health condition are that's like a shared characteristic of most, if not all, of the population of that 5%. And it may be referred to as the complex care. That's a complex care patient population group. And so I just want to tell you a little bit about my experience and why I'm so passionate that my peers and I can access community health workers. My first time at the MAC in 2017 was me standing in front of a room, just crying and begging for you to expand Medicaid. And I'll try to not cry today. But for so many of us, when we're navigating our lives and when we're trying to access critical health care, there are clusters of social barriers that we may face. So in my experience, shortly after the accident that I was in that gave me a traumatic brain injury, it wasn't too much later that I lost my job and lost my health insurance and lost my savings account and lost my car and lost my apartment. And like your life kind of like, again, it just kind of these barriers like often cluster, and a crisis, it's not usually just like one thing, it's a variety of things. And so often throughout my experience, my family and I, my family lives out of state, but I'm really lucky to have a supportive family, but we just like never knew where to turn to access help to try to navigate like so many of the frustrating barriers that were just constantly being dealt with. How you learn how to like live so many parts of your life over again while simultaneously like feeling like the conditions of the community that you live in are not set up for you to thrive. And it's a really frustrating and stigmatizing and sometimes, oftentimes, I think it really drives a lot of the mistrust that we see, which is on the rise and which we know has like that is affecting so many members of our Medicaid population. And I'm sure that even for those of you that maybe you've never been on Medicaid or you don't know exactly that part of the experience, I'm sure that any of us that know whenever it's just like really hard to figure out how to get what you need and you hit roadblock after roadblock, and it's hard to just like it's just hard to be optimistic sometimes. It's hard to like keep trying. And so there are just like we have people who just like don't want to even engage in the systems because it doesn't actually feel like the systems and the social services and hospitals and clinics and like all these things just don't always feel like they're set up for you. And so it's just like can be really overwhelming and it can lead to disengagement. And disengagement obviously is like going to then connect to like an increase of burden of disease. Like it just like kind of snowballs, right? And one of the reasons that I'm so passionate about the work that community health workers do, and for those of you that aren't familiar with community health workers, they're frontline workers who oftentimes come from the communities that they serve. They have, they may live in their, they may live within the same community, or they may share a particular characteristic with the community members that they're serving, and they have an ability to access a more trusting connection so that these community members can feel like they can ask the questions that they have, and that they can navigate through the resources and the systems that are ultimately will help them to move forward. And I know that in the pandemic, I know that there's been an increased awareness of community health workers in our state as they've done so much to help people access testing, to help people access vaccinations. Like I know that for myself, like the way that the vaccine process was set up originally was like not going to work for me. I didn't have, I trying to figure out how to like fill out the right form online and just like all these like online things wasn't working for me. And a community health worker was able to get me an appointment, and I was able to just like go to like a local church and get my vaccine. And there's just so many examples of community health workers helping people to access resources during the pandemic that they just otherwise would not have accessed. And as the workforce has grown and has demonstrated how incredibly critical and how much their work is saving lives, and as the workforce has grown, one of the things that we really need to do is make sure that there are sustainable funding mechanisms in place. And a part of like what Medicaid funding can do for community health workers is to sustain their workforce so that they can continue to serve the public, and that they can especially make sure that the services that they are providing, that Medicaid members can access these services, which will help Medicaid members to increase patient engagement in the systems and ensure that they are receiving appropriate care. So making sure that someone understands the difference between urgent care, for example, and emergency department care and things like that, accessing housing and accessing food resources. And while no one's going to say that they're going to be able to solve all the problems, because like housing shortage is like a real issue that's like there's not one workforce that's going to just be able to solve all of that. Having a trusted resource for Medicaid members, would really positively impact Medicaid members. So I'll just like wrap up really quickly and just say a lot of states have done a lot of things to support community health workers. And so the policy and how the policy is written, some of those specifics I won't get into, but I did want to just like read a quick quote that I that the Department of Medicaid helped work on, or they did work on, and it's just about the cost of community health workers. So for each Medicaid member, it's expected that the cost would be approximately 5,000 years per member. And so there are like a lot more specifics about what population group and how is it structured and things like that we won't get into today. But I mostly just wanted to come before you and ask you to invest in the people that have just, they've borne so much of the burden of disease in our country and so many social barriers. And we really, I ended up crying anyway. We need to invest in them. We need to invest in relationships and connections that will bring more trust into their lives, so that they can access the resources that will change how we navigate through the world. When I learned how to use public transportation, it created independence for me that I was not sure I was going to, be able to access whenever I lost my ability to drive. Like, those things make a big difference. And community health workers are a big part of like the gateway and the path to helping Medicaid members have more autonomy and agency in our lives, and to be more empowered, and to build our trust, and to just like help us navigate very complicated systems. And again, they're not like going to fix everything, but I just want to say how important it is and how much we need community health workers to serve this population group. So anyway, thanks for your time. And also Gina's hand is raised. Sorry.
Hey, Stephanie, I just want to chime in with local health departments. We have community health workers embedded with us. And just for an example, today, my community health worker is reaching out to Medicaid clients, and she found a client today whose son, she's concerned that he has some hearing loss. And so we got him in for some hearing screening. But she's teaching a prediabetes class. She's doing developmental screening. She's doing postpartum depression screening. She's doing translation services. She does a lot more that I don't even know, but I utilize her in some of my home visitation programs. I utilize her to help my Medicaid clients. I have her help people sign up for Medicaid and fill out the form. And so I try to utilize her in as many ways as I can. And so I just wanted to let you guys know how we're using our community health workers.
Thank you, Gina. I really appreciate that, and appreciate the community health workers at local health departments across the state. So thanks for sharing that.
Hey, thank you, Stephanie, for sharing. We're going to move now to Mary Ann Neff.
Hi, my name is Mary Ann Neff. I'm the owner of Northern Utah Case Management, and I'm a provider for Employment Personal Assistance Services, otherwise known as EPAS. This is a smaller program on Medicaid, so we often find that it's not as well known throughout the state. It serves 239 adults currently, and a lot of these individuals are on the DSPD waiting list for services. So that on average, we find that most of the people want to transition into a DSPD service or qualify. Not everybody on EPAS qualifies for a DSPD waiver. The purpose for my presentation is that the wages are, again, falling far below the fair market value, and we are facing a staffing crisis with this service, not just for the direct care staff, but for all providers with EPAS. The wages are far below fair market value. I want to start with just two quick stories from clients that we have within our own company. And I should point out that our company serves 86 clients across the state of Utah at this time. We have an individual that just came into our services, and he works full-time. So in order to qualify for the program, you have to be a disabled adult that has a job in the community, and the services are designed to support you within the home to ensure that you can maintain the job and be successful in your home life. He works full-time, has spinal muscular atrophy, and currently right now, he is reporting that it is taking 4 months for him to find personal care services, meaning that the provider that he has hired is on average has a 4-month waiting list for individuals before they can receive any services and supports because they can't find anybody that will work for $13 an hour. He's starting to develop bed sores, and he wanted to point out to this committee that it costs less to keep him at home than in a group home. But if he can't receive the supports that he needs within his home, that is his only option because he physically cannot turn at night and needs the supports. Another individual receives self-administered services. I would like to point out that EPAS has been successfully providing caretaker supports for the duration of this program. And so many of our individuals do hire their own family members and parents to be able to be their staff successfully, but not everybody has that as an option. So we have an individual that's been in services for 8 years and cannot find staff to work shorter shifts within the home. She's reporting that she's having to hold her bladder throughout the day because she doesn't have staff coming in to take her to the bathroom. And so imagine having to hold your bladder for over 8 hours during the day because you cannot get yourself to the bathroom because nobody will do it for $13 an hour. I want to point out that DSPD waiver services received, through the community supports waiver and the brain injury waiver, received additional funding this last year, and this is greatly impacting EPAS services. As beneficial as it is for that industry, it is hurting our industry because it is taking the staff that otherwise would work in Medicaid-only funded programs. I want to point out that the legislature had the staffing crisis as their #1 priority for the Social Services Committee. And that is with rates that were already higher than what what EPAS was paying. So just as a comparison, a supported living provider right now through the community supports waiver receives $35.16 an hour. EPAS is at $21.28 an hour. So it's not comparable. We have this across the board with self-administered services and all EPAS services. Right now, a case manager for EPAS services is at $23.28 an hour. That is over $11.88 less than what staff, anybody that they can hire over the age of 18, no degree or background in disabilities, can be hired for a waiver to work direct care staff. So we're having to hire case managers for under what the fair market value is right now for direct care staff, and it's not sustainable. As such, our provider or our company alone picked up cases south of Provo to do them virtually. That's the only way we can do rural at this time. And in talking with the EPAS coordinator, they had lost over 50% of the case management companies this last year because of the rates. We are finding the same thing with our providers. Our clients typically only have 1 to 2 providers to choose from. Many of them are starting to discontinue taking clients or have month-long waiting lists for their staff. Just as a final note, the waiver services, I know they're not fully comparable because it's state matched, but for the purposes of EPAS, it is very valuable to know those rates because that's who we have to compete against for staff, both for case management and for direct care staff. Their rates right now are 43 to 60% higher than EPAS. So there's a huge discrepancy. Their rates were increased 16% in April from last year. And the rates for EPAS, I have an employee that's done it for 15 years. She says in that time, the case management rate has never gone up and direct care staff wages have only gone up 1 time. So if there's any questions, I'd be happy to answer them if I know the answer to it.
I could throw out, this is Dave Park again. If I could throw out just some support, Marianne, the EPAS code that is billed is that same S5125 that I talked about.
Okay.
Most of New Choice Waiver and Aging Waiver use that code. That's the 80% of the time that's the code billed, and it does bill at 2128. So I know that's, we haven't picked up any more EPAS, unfortunately, just because we just can't. So
thank you. That's very helpful.
Michael.
Yeah, I'm an analyst for Medicaid, and I'm just maybe you already mentioned it, but I didn't catch what is like the exact percent increase you're looking for.
At this time, we'll take what we can get realistically because we know there's a lot of requests. But I think that we are looking at realistically within that 30% range, or you're going to see service providers shutting their doors because they can't compete with the fair market value of what somebody else can go somewhere else to work. I understand that Medicaid programs are generally going to run lower than a waiver program, but if we market it too far below, then the Medicaid program just can't stand it all.
Okay, thank you.
Okay, thank you, Marianne, for that presentation. Next, we're going to go to Andrew Riggle. Is he still on?
I am Sharon.
Perfect.
Hi, everybody. I'm Andrew Riggle. I'm the public policy advocate for the Disability Law Center. About 82,000 adults and 34,000 Utah children experience the most serious mental illness or emotional disorders. Around another 30,000 of the state's uninsured residents experience serious psychological distress each year. Less than half receive treatment. Utah needs to substantially expand programs ensuring people with significant mental illness receive appropriate community supports, with an emphasis on case management and wraparound services. Georgia found fully integrating peers into treatment teams generated a cost savings of $5,494 per individual. Therefore, we recommend significant resources be invested in a statewide standardized, comprehensive certified peer support specialist program, including a Medicaid billable rate covering a living wage and full benefits. The number of intermediate care facilities for individuals with intellectual disabilities decreased from 18 to 14 between January of 2018 and June of 2022. Similarly, the number of beds has fallen from 655 to 472 over the same period. Under the state's current model, financial viability requires full facilities. While the legislature increased it earlier this year, $204 a day still makes Utah's daily rate the second lowest among eligible states selected by DOH. Comparatively, Tennessee's average is $488 a day. To fulfill the promise of the ADA's integration mandate while improving the system for those choosing to remain, a substantial increase in the daily rate is necessary. This is especially critical given what the pandemic taught us about risks to facility residents. Additionally, individuals leaving an ICFID with conditions requiring a higher level of medical care can continue to receive nursing services. However, those already on the community supports waiver or about to age out of the tech-dependent waiver at 21, needing a similar level of care, do not have access to these services. To meet the state's Title II obligations and ensure all waiver enrollees can fully participate in their community, we would appreciate the MAC prioritizing this $4 million request highly once again. Regardless, it's crucial DOH at least review the scope of nursing services available across the spectrum of community-based services to ensure appropriate nursing care is sufficiently funded for all eligible individuals. The limited supports waiver offers family, behavior, employment, and other supports designed to prevent or delay the need for more costly residential or facility-based care in the future. While we appreciate the 80 slots expected to be added this year, we'd be grateful for the MAC's advocacy of additional funding to keep hundreds more individuals in their home or community for as long as possible. In support of this goal, we also fully endorse the previous request to permanently fund caregiver compensation as well as restore home health and increase EPAS reimbursement rates. Some DSPD providers are already being forced to offer fewer opportunities to participate in community activities, having to consolidate operations or discharge individuals from services altogether. The situation's compounded by the fact that the $2 million appropriation request for competitive and integrated community-based employment from 3 years ago was short-lived, as was the $250,000 $250,000 to increase transportation rates. If the system is going to comply with the HCBS settings rule by 2023, we must invest significantly more in these and other areas to help providers transition their businesses to support an individual's full participation in the larger society. And I'm happy to answer questions if there are any.
Okay, thank you, Andrew. I'm not hearing any questions. Thank you so much for your presentation. We've got two more to go here. Gabriella, are you still on to do postpartum? And make sure that I'm showing the slides that you want me to.
I am. Thank you so much. Good afternoon, committee members. My name is Gabriela Archuleta. I'm the Public Policy Director at YWCA Utah and co-chair of the Maternal Mental Health Policy Committee. I'm here to present to you two requests. The first is to ask you to consider opting into a new provision of the American Rescue Plan that allows states to extend Medicaid postpartum coverage from 60 days to 12 months. This is available over the next 5 years through use of a state plan amendment. Currently, 25 states are implementing this program. The second request is to consider increasing the pregnancy income threshold to 200% of the federal poverty level. Last month, our committee held a press conference commemorating Governor Cox's declaration of May as Maternal Mental Health Awareness Month. We heard from two survivor moms, one of whom is the wife of Senator Thatcher. Both of these women nearly lost their lives to postpartum mental health conditions. Both of them had access to health insurance coverage and were able to access intensive treatment that lasted several months. Not all Utah mothers are as fortunate to have access to life-saving insurance coverage during the postpartum period. Utahns are experiencing postpartum depression and anxiety at alarming rates, and we must ensure that all postpartum individuals have access to consistent mental and health benefits. Opting in to expand postpartum Medicaid coverage to 12 months will improve mental health and coverage stability and will address racial disparities. Extended coverage will improve maternal mental health. Postpartum depression and pregnancy-related anxiety continue to be a serious public health issue affecting almost half of Utah mothers, and they are the leading complications of childbirth, higher than preterm births, low birth rate, and gestational diabetes. Extended coverage will improve coverage stability. Currently, 65% of pregnancy-related deaths occur from 43 days to 12 months postpartum. 12% of deaths occurring in the late postpartum period are preventable with adequate care and coverage. Medical conditions such as cardiovascular diseases, hypertension, and depression require longer-term care and coverage. Additionally, churning is common. 65% of women covered by Medicaid or CHIP at delivery were uninsured for at least 1 month during pregnancy. And 6 months after childbirth, 55% of these low-income women had a gap in coverage for at least 1 month, and 25% experienced 2 or more uninsured months. This policy will also address the coverage gaps for mothers whose income rises after birth and is too high for adult expansion Medicaid, yet too low for marketplace subsidies. Extended coverage will also address racial disparities in maternal health care. Women of color are disproportionately increasing barriers to health care, and racial disparities are impacted by social and economic inequities. In Utah, women of color experience higher rates of postpartum depression. Additionally, I am here to ask you to consider increasing the pregnancy income threshold to 200% of the federal poverty level. This is important because more pregnant people will be able to get the comprehensive benefits of Medicaid health insurance, including counseling, behavioral health, and dental. Increasing the income threshold to 200% of the federal poverty level means that mom and baby will have the same income eligibility requirements. Right now, babies are eligible for CHIP up to 200% of the federal poverty level, but moms are only eligible for up to 138%. Many states extend eligibility to pregnant women with incomes considerably higher than this threshold. States have considerable discretion to determine the specific scope of maternity care benefits. Currently, Utah is second to last in Medicaid coverage in the pregnant woman category. Nearly all states have expanded Medicaid eligibility for pregnant people. Some have these eligibility upwards of 300%. Iowa's at 380%. South Dakota, Idaho are tied for last, followed by us and Alabama. So this increase would put us in the middle. Improving maternal and infant health is key for preventing unnecessarily illness and death and advancing overall population health. These policy options will address gaps in perinatal coverage and will improve the health and economic stability of Utah families and our state as a whole. I ask that the committee consider the needs of Utah moms and families and extend pregnancy Medicaid to 12 months and increase the pregnancy income threshold to 200% of the federal poverty level. Thank you for considering these requests for funding.
Thank you, Gabriella. Is there any questions? Okay, so we've got Scott, Alpine Home Medical Equipment. Are you on to give your presentation?
I am here. Thank you. Can you hear me okay?
We can. Thank you.
Great. Thank you for letting me be a late entry, and it looks like the last entry to the agenda today. I apologize for the late hour, and I'll try and keep my comments brief. I did, however, want to talk just a little bit about the durable medical equipment industry and some of the provisions or proposals in the SPA as they relate to medical supplies and equipment. Alpine Home Medical has 10 locations throughout the state of Utah. And as we've heard over and over today, our costs continue to rise, both in product acquisition, staffing costs, and most notably right now, fuel and delivery, which is much of what we do. Our current reimbursement with the state is based on CMS, Medicare published rates, and it's a percentage below that. Currently, it's at about 90% of published CMS rates. One thing I want to talk about today is CMS's rates were based on a program, a very publicly and well-known flawed program called National Competitive Bidding. That program happened about a decade ago. And at that time, we lost about 40% of DME providers across the country. Yeah, because the rates were driven down 30 to 50% on most of the products we offer. So again, if you take those rates, compound them by another 10% with the state Medicaid, we are just in a tough spot. Not only have we not had price increases in over a decade, we've had multiple and significant price decreases. So our ask for today really would be that the state consider increasing rates for DME, for medical supplies and equipment. We would like to see those rates increase to 100% of the published Medicare rates, and we think that's reasonable. We also would ask that the state clarify the language where it refers to lesser of rural rates versus non-rural versus competitive bid area. And we make sure we're indexing to all three of those rates based on where a member lives and resides by zip code, which is the way that Medicare does that. That would be our main request and ask today. I would also maybe draw attention to rates that are not established, where reimbursement is not established by Medicare. We would ask that that reimbursement be based on a discount off of billed charges, or suggested retail pricing rather than on a cost plus basis. Most of the manufacturers publish suggested retail pricing, and we would ask that that be a consideration that we take a discount off of that rather than looking at a cost plus methodology. Alpine is a full service provider. We offer all the services that Don Clayback spoke of earlier, the high-end complex rehab, all the way down to basic equipment that you would use in your home, like crutches, canes, commodes, etc. So again, very full service provider, but our costs continue to rise. They're at an all-time high, and we're losing providers. And at the proposed rates, I think the state's going to continue to see a loss of providers, as well as issues with access, both in urban areas as well as more so even in the rural markets. So that's what I have. Again, I don't have a formal presentation, but I did hope to point out a few of those things to the committee. Your time is much appreciated. I'll open it up for any questions.
Looks like we have a question from Don Clayback.
Yes, thank you, Sharon. Just to add to Scott's comments, and I know time is late, so I won't go into detail. We'll be following up with the department, but we frankly just found out about this yesterday, and to be candid, we're still kind of recovering. I talked earlier about the need for this complex rehab technology providers and all the additional costs that they're incurring, and really thinking of what services they're going to have to drop that are keeping, people with disabilities independent and outside of medical interventions and other costly medical treatments. And to see that, there's a proposal to decrease the current rates by almost 9%, we really just don't understand that. So for today, we just wanted to go on record that to let this committee know that we're very concerned about it, both from the complex rehab technology providers, and also, as Scott said, his company is a full line provider. But when you're looking at, oxygen equipment in the home, other respiratory equipment, keeping people out of the hospitals, providers are really suffering from some very low reimbursement rates. And to now have to be battling a 9% reduction, frankly, is discouraging. But for today, we just wanted to go on record, and we'll certainly look for an opportunity to expand on that over the next few days. Thank you.
Okay, thank you, Scott. Thank you, Don, for your comments. That is all that I had that contacted me. So unless there's anyone else who would like to make a presentation, Jesse, I will turn it over to you.
Thank you, Sharon. Thank you so much to everybody who shared and made these presentations. And Sharon, also thank you to all the coordination that goes into getting the materials together and keeping us on track throughout this meeting. So I just want to give a shout out to you. Thank you for the work you did. I feel this hearing, I think, is probably the toughest for all of us over the entire year, because we hear how many issues are so important. And but I feel really grateful that there's space in this committee to hear and to elevate these issues. I mean, the prioritization process is what it is, but I think what's incredibly important is also having this time to hear every issue. And so thank you all so much for being here, for staying late, and for continuing to work together to improve care for everyone, for all of us together as a state. So with that, I think we have additional materials that Sharon sent out. We won't obviously have time for those today, but please feel free to look through them on your own time, and we'll revisit them in the July meeting, where we will be prioritizing them. But just to be clear, I think, these are all critical issues, and it's important that, that I appreciate the department for considering all of them, and that, every issue that has been raised today, I think, thank you everybody for listening, because we know that there's work ahead of us to make progress together. So thank you, everyone, and have a great evening. Stay safe and cool, and we'll see you in July. Thanks. Thanks again, Sharon. I really appreciate it.